So today's chapter is Devita number chapter 53, malignant tumors of the breast, incidence and etiology. Worldwide, breast cancer is the most frequent diagnosed cancer and the leading cause of cancer death among females. And it accounts for 25% of the cancer cases and 15% of the cancer deaths in women. Although there is fourfold variations in the mortality rates and tenfold variation in the incidence rate between high incidence areas such as United States and Western Europe and low incidence states such as Africa and Asia, in 2021 there were an estimated 284,000 new cases of breast cancer in United States with 44,000 deaths, and between 1950 to 2020 death rate from breast cancer declined in the US by 40%. Similar reduction have been observed in other countries. Adoption of screening mammography and the use of adjuvant therapies have contributed equally to this improvement. Though traditionally less common in non-industrialized nations, breast cancer incidence is increasing in low and middle income countries. Risk factor for breast cancer. Multiple factors are associated with increased risk factor for developing breast cancer, but the majority of these factors convey a small to moderate increase in risk for any individual woman. At least half of women who develop breast cancer have no identifiable risk factor beyond increasing age and female sex. In 2019, an estimated 11,870 invasive breast cancer and 1,070 breast cancer deaths occurred in US women younger than 40 years, compared with 256,000 cancers and 40,000 deaths in women aged 40 years and younger and older. So familial factors. Familial in history of breast cancer has long been recognized as a risk factor for the disease. However, only 5 to 10% of the women develop breast cancer have true hereditary predisposition. Overall, the risk of developing breast cancer is increased 1.5 to 3 fold. It increased 1.5 to 3 fold if a woman has a mother or sister with breast cancer. Family history, however, is a heterogeneous risk factor with different implications depending on the number of relatives with breast cancer, the exact relationship, age at diagnosis, and number of unaffected relatives. Even in the absence of known inherited predisposition, women with a family history of breast cancer face some level of increased risk, likely from combination of shared environmental exposure, then lifestyle features, unexplained genetic factors, and a combination of these factors. So, inherited predisposition to breast cancer. Mutation in the germline BRCA1, BRCA2 are associated with a significant increased risk of breast cancer and ovarian carcinoma, and these mutations are inherited as an autosomal dominant fashion after varying degree of penetrance. And the estimated lifetime risk of breast cancer development in mutation carriers ranges from 26 to 85%. The risk of woman cancer ranges from 16 to 63% and 10 to 27% in BRCA1 and BRCA2. Risk of ovarian cancer in BRCA1 it is 16 to 63%, BRCA2 10 to 27%, and more than 700 mutation of BRCA1, 300 of BRCA2 have been described. Position of the mutation within the gene has been shown to influence risk. The presence of BRCA1 BRCA2 mutation may be suggested by the family history at the maternal or paternal side of the family. Risk reduction strategies in BRCA1-2 mutation carriers include intensive surveillance, chemoprevention with the SERM selective estrogen receptor modulators, prophylactic measures like mastectomy, salpingo-oophorectomy, and of note, women with a significant family history of breast cancer, 2 or more breast cancer younger than 50 years, or 3 or more breast cancer at any age, but who test negative for BRCA mutation, have approximately a 4-fold increased risk of breast cancer. Roughly 10% of such women will be found to harbor genetic predisposition on the larger panel testing. By contrast, women with families with known BRCA mutation but who test negative for the mutation are not at increased risk and do not require special surveillance. Women with BRCA1 mutations have a higher incidence of high-grade tumors. that lack estrogen receptor, progesterone receptor, and human and HER2, human epidermal growth factor receptor 2. That is triple negative breast cancer. Then sporadic cancer. The phenotype of BRCA2 cancers do not differ from sporadic. A number of features of the tumor, the patient, and the family history help to guide whether a patient warrants further personalized risk assessment and genetic counseling with consideration of the genetic testing. Factors often considered include young age at diagnosis of breast cancer, less than 45 years or younger, male breast cancer, triple negative breast cancer, and certain familial history or other personal cancer history. Ashkenazi Jewish ancestry is also considered to be an irrelevant risk factor in the guidelines because carrier frequency of specific BRCA1 and BRCA2 of this group, that is 187 deletion AG and 617 deletion T, of this group is 1 gem 40 compared with the 1 gem 500 in general population. Models are also available estimated the likelihood of BRCA1 BRCA2 mutation based on the family history, and the implication of the genetic testing for both the individuals and the family members are considered, and this issue should be discussed with them prior to undertaking genetic testing. Another genetic mutation having associated with the BRCA cancer is although with a lower prevalence or penetrance than BRCA1 BRCA2, P53 and P10 they account for less than 1% cases, whereas CDH are associated with the autosomal dominant predisposition to diffuse gastric and lobular breast cancer. Younger women with P53 leave from any this have a greater propensity to HER2 positive breast cancer. Younger patient leave from any have HER2 positive breast cancer. Mutation in the low penetrance genes are thought to account for a significant number of the non-BRCA1. Mutation in low penetrance genes are thought to account for a significant number of non-BRCA1, non-BRCA2 breast cancer. A specific mutation of the checkpoint to CHEK2 was found in 11.4% of the families with 3 or more cases of breast cancer diagnosed before age 60 years. In a large study of 10,000 unselected breast cancer patients from 5 countries, the CHEK2 mutation was identified in only 1.9% of the cases and 0.7% of the controls. Risk of breast cancer has also been shown to be elevated in carriers of germline loss of function mutation in PALB2, a nuclear partner of BRCA2. So PALB2 is a nuclear partner of BRCA2, with an estimated cumulative risk of breast cancer is 35% by the age of 70 years. Increasing patients are undergoing genetic testing with multi-gene panels, including genes associated with the cancer such as BRCA1, 2, PALB2, BARD1, CHEK2, CDH, 180M, P53, P10, helping clarify some cases of familial cancer but increasing the detection of variants of uncertain significance. And recent analysis of 34 known or suspected breast cancer susceptibility genes among 60,000 women with the breast cancer and 53,000 unaffected control participating in 44 breast cancer association consortium studies provide robust estimation of the absolute risk of breast cancer associated with protein truncating variants in the most commonly cited genes, and collectively between 8 to 10% of the breast cancer are attributed to hereditary genetic mutation identified on gene testing panels, and in the United States about half of this arise from BRCA1 2 mutation, while other genes account for approximately remaining half. Thank you.